It's really a pleasure to have an opportunity to speak to you about Choosing Wisely Canada, something I'm very passionate about, and I hope that it will be of a great deal of interest to you also. So as you can see, we are Choosing Wisely Canada and Choisir avec Soin, because this national campaign is bilingual and all of the materials I'm going to talk to you about are available in both languages. So what I'm going to do today is talk to you about, I'm going to describe the epidemic of overuse, I'm going to describe the campaign of Choosing Wisely Canada, and lastly, I'm going to really focus some time and energy on talking about the strategies to implement the recommendations of Choosing Wisely Canada, both in practice and in medical education. So this first slide is a very important one. It comes from the work of Don Berwick, who is the person that invented the Institute for Healthcare Improvement, and he also was the head of Medicare and Medicaid in the United States. And what this slide shows is the growing amount of the gross domestic product that, in this case, the United States is spending on healthcare. The United States is now at about 18% or even more of its gross domestic product. In Canada, we're at about 12%, which is still a lot. And as you can see, it's rising, and every country in the world is concerned with the rising cost of healthcare. But what's more important about this slide is not just the rising cost of healthcare, it's about how much value we get for the dollars we spend. And this slide, which Don Berwick calls the wedges of waste, shows that not all the dollars we're spending are giving value to our patients. In fact, what he describes is things that you and I see every day in our practice. Failures to coordinate care. So the emergency room doctor doesn't know what the family doctor saw in the lab work, doesn't know what the specialist saw, and then we often end up repeating tests. Failures of care delivery, where we might not prevent diabetic complications, and then we have more complicated care that's harmful and difficult for patients and expensive because we didn't prevent the nephropathy or the diabetic problems. And there's a big wedge of waste, which Don Berwick calls overtreatment, and I would call it overdiagnosis and overtreatment. And this is the focus of Choosing Wisely. And just to put a little perspective on it, the Institute of Medicine in the US estimates that 30% of all the dollars spent in healthcare do not add value to patients. And while you might think, well, that's a US number, I'm going to tell you later that in our Canadian research, this 30% keeps reappearing. And probably in Canada, we also experience a good deal of the healthcare we spend not adding value, or maybe even being harmful to our patients. So next important concept is, of course, how do we end up not adding value? Well, of course, we don't get up in the morning as physicians to treat the gross domestic product. We get up to treat our patients. But in treating our patients, we make many small decisions all of the time that influence the value that's delivered in healthcare, determining which patients are seen and how frequently, which patients are hospitalized, which tests and procedures or surgical procedures we do, which new technologies are used, and I will say that there's a lot of interest in both doctors and patients on new technology, and which medications are prescribed. And in general, the research shows that physicians determine 80% of the tests and treatments that are provided in the healthcare system. So patients often say to me, well, Wendy, why would doctors order tests that aren't needed? And I always say, it's complicated and there are many components. And on this slide, what you see is what I think contributes to why we order things that may not be needed. So of course, patients want it. We've all had the experience, depending on our specialty, of patients coming in and saying, my neighbor had a headache and they got a CT scan and ended up having a brain tumor. I have low back pain and I would like an MRI of my lower back. My child was up all last night with an earache and I need antibiotics. So they're patient expectations, and I would say this is particularly true in the primary care setting, and we often want to meet the expectations of patients. I mentioned to this already, but new tests are good. So, even in Canada, we see direct-to-consumer advertising from the US. that shows us how this amazing new technology will save your life. And so patients come in often wanting new technologies. And physicians also, we're in a culture where new technologies are good, and so there is a drive for more new technology. This next bubble says it's better to do something than nothing. I think what I really mean by that is sometimes it's hard to tell patients why they don't need something. In fact, it could take a lot more time than just ordering it. And I know that if I'm busy or behind, sometimes it's easier to just check off the box. But in Ontario, there's the College of Family Physicians runs a workshop called Don't Just Do Something, Stand There, because they're trying to counteract this dilemma that we feel that it can be more time and effort to explain what a patient doesn't need than just to do it. There's a very interesting one, which is that what happens between us as referring physicians. Family doctors tell me all the time that they get a letter back from the consultants that says, do the following tests. They don't really think it's all needed, but the consultant said it was, so they feel obligated. And consultants say that family doctors referred the patient to get a particular test, and so they feel like they need to meet the expectations of the family doctors. So I think we do a little bit of this in the referral process, and that leads to over-ordering. Of course, another bubble is I don't want to get sued, especially in emergency departments. Physicians are quite worried about if they don't do it and there's a complication, what the implications will be. There are misaligned financial incentives, so that sometimes physicians are paid more to do more, even if it's not added value for patients. But I'm going to tell you that despite all these bubbles, I think this last bubble is the most important. I've always done it this way, because I really think what happens is that we learn a way of practicing from the beginning of our medical education, through our role modeling and our residency. And when we see a patient with X, we've learned to always do it this way, to work them up this way. And once we've embedded those patterns, it's harder to change practice. And there's a lot of research I don't have time to talk about that shows that we embed this early in medical education. I will show you later some very exciting work that's happening in choosing wisely. So the point of this is there are a whole lot of reasons that we might overorder something that really isn't needed and adding value to patients. So as Ezekiel Emanuel, who has been a consultant to Obama in the White House, says, we physicians are the only people that can get healthcare costs under control. And I say what Jerry Garcia from the Grateful Dead says, somebody has to do something, and it's just incredibly pathetic that it has to be us. But I really think it has to be us. We physicians are in the room with our patients. We know what the clinical situation is, and so we can make judgments and help to work with patients to have conversations. And so choosing wisely is a campaign to help physicians and patients engage in conversations about unnecessary tests and treatments and help them make good quality choices. So it really, at its heart, is about engaging in these conversations to improve the quality of care and prevent harm to patients. And I think that this conversation, where we live and breathe, this is what we get up in the morning to do, is to interact with our patients and talk about what's best in their care. And this is how the campaign is shaped, and it is its core important element. So just to give you a little bit of background about the campaign, it began in 2012 in the United States. I was involved in the creation of the campaign there through the American Board of Internal Medicine Foundation. And now there are quite a bit, over 70 medical societies participating. In Canada, we launched just a year and a half ago in April of 2014, and we have more than 45 national medical societies participating in a way I will show you in a moment. And what's very interesting is it's now spreading internationally, and I'll talk about that too. So the campaign approach is pretty simple, and actually the campaign being simple, I think, is a strength of the campaign. And what we've done is to try to engage with the societies, and I bet many of you have actually seen some of the lists from your own specialty societies. We've worked with the medical societies like Canadian Cardiovascular, Canadian College of Family Physicians, the Canadian Association of Radiology, and asked each of these societies to create a list of initially 5 things in their discipline for which there is excellent scientific evidence of overuse or even harm to patients. And the societies have been just terrific in doing this and have welcomed being part of this campaign. And then they have disseminated this to their membership through multiple channels, their publications, their meetings, etc. The second component has been developing patient materials, and I'll show you some of these. Because it's a conversation, and as I mentioned before, often patients may request these things, we've worked with Consumer Report in the United States, and then we've modified them in Canada to create a whole set of patient materials to help educate patients at the point of care. Third, we've tried to work with the media to get the word out because we think this does need public attention. And fourth, we've worked with many of the stakeholders, and so that is the provinces, it's the provincial territorial medical associations, it's many hospitals and family physicians and organizations to try and work with those networks to get the word out. So for example, here is the list of the family physicians who, as you'll see, says 11 things physicians and patients should question. And I just told you 5, but what has happened in their society and many others is they've added additional ones over time. So there are now 11 recommendations. I don't expect you to read this in detail, but here's what they all look like. So this is a sample. Don't do imaging for low back pain unless red flags are present. And then there's a little explanation under it that's the rationale and would explain what red flags are. And then below the list are the references and the way the society created their list. And so each of them really follow this format, typically starting with the word don't do or avoid. And they're all, of course, we're not saying never do these things. You would do these imaging for low back pain if there were red flags, but it's really to have the conversation with the patient if there are no worrisome findings. So all the lists look like this. Now the patient material, and again, I'm not asking you to read this in detail, they have this kind of format. So this is low back pain, and what it says is imaging tests for low back pain, when you need them and when you don't. And then they typically explain that they don't help you get better faster, that they pose risks. And what I want to say is a very important part of these brochures is they not only explain direct risk, like an adverse drug reaction or radiation exposure from a CT scan, they explain false positives. And you and I know as physicians that patients really don't understand the concept of false positive. They will frequently say, well, what's the harm? Let's just get another test. But we have all seen in our clinical experience patients who had a test and then had a complication, or a false positive and then a complication, leading to that cascade of medical problems. So they explain false positives. And then they always say when the test does make sense, because we are saying that sometimes it should be used. And lastly, they have this little panel on the side in color that says what you should do to treat your low back pain. So there's suggestions for patients. And we've done extensive testing of these patient pamphlets in Canada, and the patients we've tested it with give us very positive feedback about how useful this information is. So these are all online under the Choosing Wisely Canada website, and as are the recommendations, and feel free to log in to choosingwiselycanada.org and help yourself to any of it. So in aggregate, this little slide captures, we have almost 200 recommendations. We've worked with all the provincial territorial medical associations. We have the patient materials. But what I also want to point out is at the bottom of this little logo is the Early Adopters Collaborative, and actually the number is more than 35 now. What we've been doing is working with all kinds of groups around the country, hospitals, family practice clinics, regions, who want to implement the Choosing Wisely recommendations. And I'm going to give you examples to date, but on our last webinar, for example, we had over 70 individuals and organizations involved in learning from one another about how people are putting them into practice. And I'll tell you about our student movement in a moment. So we have tried to create, as I mentioned, all kinds of materials to make it easier. I mentioned the patient pamphlets. We have an app that's free on both Apple and Android that have all the Choosing Wisely recommendations that please download even while you're listening. There are CME programs that are free. This is the website for one of them that was created by the Canadian Medical Association, who's been a key partner for us in all of this work. I should have mentioned that earlier. But there's all kinds of, this is a CME that you can get credit for. This slide just shows you how many countries around the world are starting to pick it up. There are now 16 countries. The Canadian group leads this consortium, ranging from South Korea and Japan, many European countries, Brazil, and the US and Canada, of course. And I think really what it shows is that this message about physicians engaging and leading an effort to change the culture of overuse, which has pervaded our medical environment, is something that resonates around the world. And physicians find this message just fits with them. In fact, I recently was at a meeting in Switzerland where they hoped to have 200 people attend, and over 500 people came to hear about this initiative. So I think it's very much resonating with our culture as physicians, not just in Canada or North America, but really worldwide. Now, I want to take a moment to talk about medical education, because I'm sure that many of you are involved in medical education. And as this slide shows, trainees have the same bubbles in their head as we do about why they might overorder. But they have some other ones that you as teachers can address. Residents want to show they've been thorough. So what happens is that a resident wants to make sure that when the attending physician comes in the next day or in the clinic, they've ordered all the appropriate tests to rule out everything it can be, because we've built a culture where having a broad differential diagnosis and making sure it's none of those things is the right thing for a good resident to do. And so they often need to overorder, or they feel a need to overorder, even though they know it's probably not necessary. Residents lack feedback, and actually I would say all of us lack feedback. You know, when did you last get feedback about whether you personally or when did I get less feedback about if I overorder more imaging tests than my colleagues or more blood tests than my colleagues? Really, often we don't get any feedback, so we don't know that we might be ordering fewer or more or whatever. Residents do preemptive ordering. So if I get that CT scan tonight, maybe I can shorten the length of stay tomorrow. So it might not be needed, but let's just get it tonight in case. And so they call that preemptive ordering. And the most important one is the same as I mentioned before, is how we were taught, that residents learn early in their training and this pattern gets reinforced. So again, residents are learning these patterns. And there is a growing movement around the United States and Canada to change this in medical education. This is one website for any of you who are interested called teachingvalue.org. There's an organization called Cost of Care. On this website, there are lots of videotapes about how to teach this and trigger tapes to stimulate conversation. But I'm really proud of this, which is an initiative of our own Canadian medical students. They work with us in the summer, and they've created an organization called Choosing Wisely Canada STARS. And STARS stands for Students and Trainees Advocating for Resource Stewardship. And one of the things they did, of many, is they created a list of 6 things students should question. So we haven't even released this yet, but here are their 6 things, and I'll give you a sample. Don't suggest ordering tests or treatments preemptively for the sole purpose of anticipating what your supervisor would want. So these are students themselves. They actually sent this out to a consultation of the 8,000 students in Canada and had over 2,000 students write back and order these and give them all kinds of feedback about the campaign. And they're now creating a leadership group of these students. So I know that many of you then really are asking the question, so what about when you try to put this into practice? Because of course, Implementation is where the rubber hits the road. And I'd say there's a spectrum of activities happening, ranging from education, like a lecture like this, of physicians and patients, to quality improvement projects, which many of you probably are involved in, and audit and feedback. I mentioned the lack of feedback before, so there's a lot of projects doing that, to a variety of things that are where we'd call them hard coding, like putting it into the physician electronic order entry or changing order sets to incorporate the Choosing Wisely recommendations. So I'm just going to give you a few little samples of what's happening. This is one from the US, but worth pointing out. This is Cedars-Sinai Hospital, which is a very major teaching hospital in the Los Angeles area where the Hollywood stars go. It's a very expensive hospital. And what they did was they embedded over almost 200 of the Choosing Wisely recommendations in their physician order entry. So if you go to order a benzodiazepine in a patient over 65, where it's contraindicated in many cases, you get the American Geriatric Society recommendation pop up to explain to you why they would ask you to reconsider, and of course you can override it. But on this slide you see that in a pre-post design, and actually they've continued to do this work, they find that they decrease the ordering of unnecessary or even dangerous drugs anywhere from 12%, and actually their more recent data is up to 30% in a pre-post design. Little closer to home in Toronto, North York General Hospital has been working on Choosing Wisely. It is the screensaver in their hospital everywhere. And they have some very interesting early results in the emergency department. And in this case, what they did is they tried to encourage physicians not to order lab tests that were not needed. And in a pre-post design, what you see on this slide is they reduced the overall ordering of laboratory tests in the emergency department by 41% by implementing Choosing Wisely in a variety of ways through physician and patient education, nursing education, etc. In fact, in their early impact analysis, they've done this in other settings too, preoperative clinical testing like EKGs and chest x-rays, inpatient labs, CT scans, and ICU x-rays. Some of them a smaller amount, as you might expect in the inpatient setting, but still a significant drop in a pre-post design in many of the indicators. And they've done this a lot through a lot of strategies. I'd say the most important has been physician leadership, but then of course using patient education. They have a robust component of that. They've used their electronic medical record, and so in aggregate they've been able to make quite impressive changes in a relatively short period of time. Here's another example I want to show you from University of California, San Francisco. And this, I love this box. This is the amount of blood transfusions. And so as you can see, the larger the box, the more a unit transfuses. This is done by the different components of the hospital, like hospital medicine and malignant hematology. And so hospital medicine, as you can see, and malignant hematology are very big boxes. They transfuse a lot. But the more interesting thing is the color of the box indicates whether they transfuse inappropriately. Because if, the guidelines and Choosing Wisely recommends that we not transfuse unless a patient is unstable with a hemoglobin over 80. So the redder the box, the more transfusions are inappropriate. So you can see on this map the number of transfusions a unit does, but also whether they're light pink, meaning pretty appropriate, or they're redder, meaning more inappropriate. And then what they did is they did it by doctor. So you can see in the hospital medicine one, for example, that there are some hospitalists who've got a very red box and other who have a light pink box. And by showing this, they stimulated conversations about the appropriate use of blood transfusions in their hospitals, and they have made a significant difference and lowered it. In Ontario, another example is that many of the recommendations, both the Canadian Society of Internal Medicine and anesthesia, for example, all point to preoperative x-rays, blood tests and stress tests, etc., in patients who are undergoing very low-risk outpatient procedures. And here's an example. So we found using the Ontario data system that up to 30% of very healthy patients, and then the black bars are Alberta, in Ontario it's the teal bars, are having preoperative EKGs despite being very low risk. And I mean low risk. These can be young people with undergoing an endoscopy or arthroscopy. A smaller number get chest x-rays, and even some get transthoracic echoes and stress tests. But what's really interesting also in the concept of feedback, and this is just the EKGs, every one of these dots is a different hospital in Ontario. And what you can see is that some hospitals do an EKG in a low-risk patient 3% of the time, and some do it over 90% of the time. And the biggest predictor of whether a patient gets an EKG in Ontario preoperatively when they're low risk is not their comorbidities, as you would expect it would be, but it's which hospital they happen to go into. Because these things just get baked into the system and are hence what hospitals get in the habit of doing. But if we can share this with groups and they see how they perform, we hope to, again, stimulate the dialogue, which is always our goal. And now, what we're going to start doing in Canada in the Choosing Wisely campaign is we're launching a 10 million tests and treatments challenge. That's 10 million tests and treatments that we hope to prevent that are unnecessary and don't add value. And we hope that maybe someone listening will participate in this as an individual or a group. What we want groups to do is to register, get the starter kit from us, pick a target that could be the preoperative EKGs or the blood transfusions, or in a family doctor's office, routine blood tests for annual visits that aren't necessary, to implement a strategy and to tell us how you've done in measuring change. And we hope in aggregate we can reach this 10 million campaign. For example, here's a strategy of why use 2 when 1 will do. So in conjunction with the Canadian Transfusion Society, we hope that some hospitals will engage in a campaign of why use 2 units of blood when 1 will do, and we can try to make an impact. Or here's another, lose the tube, as an attempt to decrease the use of urinary catheters that lead to complications and don't add value for patients. So you might choose to join this part of the campaign. So I want to shift, and before we end, say a few things about measurement, and I will be brief because it's a complicated area, because people ask all the time, so what's the impact of the campaign? And I've already told you that we're going to try to launch the 10 million campaign. I've given you some examples of local institutions and what they're doing, but we really think Choosing Wisely is about a culture change. And in order to measure a culture change, it's got multiple components. What do we as providers, physicians, nurses, pharmacists, what are our attitudes about overuse and our awareness of our own practices of overuse? Of course, our behaviors, and also what are patients' perceptions of all this? So I'll just give you a little snippet of where we think we are at the moment. So this is just the Ontario Family Physicians, and we did a survey in conjunction with the Ontario Medical Association, and what you can see is that our respondents, over 60% think that patients drive inappropriate use of services. I mentioned before that family doctors think this. Specialists think this less, because probably it's different in family practice than specialty care. Many patients think that physicians think that patients will benefit if we implement the Choosing Wisely recommendations. That makes sense because some of these things cause harm. And they agree that they, the physicians, are responsible for ordering the tests. And we were pleased that almost 75% of physicians, even 6 months ago, were aware of the campaign. Patients, of course, fewer are aware. We had Ipso-Reid do a survey. 9% were aware of the campaign, but this is very interesting. A third of the patients felt that they had had care that was unnecessary. They felt that a third of care in general was unnecessary, and that, that they needed, as you can see in that fourth bar, more decision support to help them know whether tests or treatments were necessary. In fact, what was interesting is a full quarter said that they had in the last year had a test or treatment recommended that they didn't believe was necessary. 44% said they asked the doctor about whether it was needed. 31% said they just ignored the doctor's advice. So that's the person that we gave the prescription to, and they just put it in the garbage can when they walked out of out of visit. And then a quarter of them actually took the test or treatment, even though they thought it wasn't necessary. So it's useful to sort of unpackage what are patients really doing when they don't think that we're ordering something that is needed. Will they speak up? I think it's very hard for patients to speak up in the power differential of the doctor-patient relationship. So we are going to launch an even bigger campaign to try and promote the message, more is not always better, and to try to educate patients to talk to their doctors. So we're going to use some imaging that we hope will get a little bit of humor going and help patients appreciate this campaign. Here's one of our posters, more is not always better, and you see the hot dog, but then it says the same is true for medical tests and treatments. Talk to your doctor about what you need and what you don't. Here's another one, a washing machine that's overflowing with suds. We hope these posters, we're going to create posters and handouts, and mainly we're going to put these in family physicians' offices so that they can be distributed there and have videotapes and screensavers to try and interact with patients when they're actually seeing their primary care provider. So really, I hope that this brief presentation helps to stimulate what you might talk about with me in the question and answer period, or in your community, to think about what you might do to implement the Choosing Wisely recommendations and how you might incorporate this into both your practice and your teaching. And we at Choosing Wisely Canada look forward to working collaboratively with you and helping your efforts. We welcome your feedback and suggestions. We're always revising the recommendations with the societies. So if you don't think we have it right, please tell us. And I thank you very much for your attention.